for joining us for today's webinar. My name is Stephanie Ince, and I'm excited to introduce the mydystonia&I webinar series that DMRF Canada is hosting in partnership with Merz Therapeutics. The mydystonia&I webinar series will focus on empowering patients and optimizing patient treatment outcomes. I'm joined today with my colleague, Archana Castellino, who is our newly appointed National Director. Archana and I are thrilled to have you with us today. The mydystonia&I webinar series offers 5 webinars during the course of September, all in recognition of Dystonia Awareness Month. Each webinar will focus on a specific area of dystonia and will feature a physician from the field. 5 separate movement disorder specialists from all over the country will be participating. Today, we're presenting our second webinar in the series, and our topic today is What's New in Dystonia. Today, we're joined by Dr. Janis Miyasaki. Dr. Miyasaki is a graduate of the University of Toronto Medical School Neurology Residency Program and a Movement Disorders Fellowship under Dr. Tony Lang. Dr. Miyasaki is currently the Director of Parkinson and Movement Disorder and co-director of the Complex Neurologic Symptoms Clinic at the University of Alberta. Dr. Miyasaki conducts research in movement disorders, and her work focuses on palliative care for neurology, communication, quality of life, and novel care delivery. She's authored several guidelines and quality measures for Parkinson's disease and other movement disorders, and has published over 100 publications in peer-reviewed journals. She also collaborates widely on an international basis. Please join me today in welcoming Dr. Miyasaki.
Thank you, Stephanie, and thank you to all of you for making time in your day to join us.
Before we get started, I'm just going to cover a few housekeeping items.
Yes.
So a very important reminder, which is that this is a webinar presentation that aims to provide dystonia patients and caregivers with tips and tools for how to live their best lives with dystonia. We urge you to speak with your own medical doctor or neurologist for a full and complete examination, and to remember that you are in control of your own health. A reminder that a recording of this presentation will be made available and emailed to all of you once it is available online. I know that we've also taken some of your questions once you signed up for this webinar, and those questions have been shared with Dr. Miyasaki, and anything that isn't answered in the presentation, we will try to get to in the Q&A section. As well, if you have questions that occur to you during Dr. Miyasaki's presentation, please feel free to type those questions into the Q&A section, which you should see at the bottom of your screen. Finally, there is also a chat function, so please feel free to use the chat function to say hi to others who are joining us today and to introduce yourself. Now, without further ado, I'll turn things over to you, Dr. Miyasaki.
Okay, thank you. And I am just sharing my screen right now. So today I'd like to go over what's new in dystonia and a little bit of what's old, just to make sure we're all speaking the same language. And I will admit that the medical language is pretty confusing. I will go over my conflicts of interest. So these are organizations that have funded my research, as well as positions I hold that might influence my thinking. Today, I want us to list terms to describe dystonia so that you can use the language that physicians use to talk about dystonia. I want to list treatments that are standard of care for dystonia and understand the licensing and approval process of drugs in Canada to a smaller extent, and list new treatments that are reported in investigation. So the first is dystonia. So much of medical terms is derived from Latin, and dys means abnormal or unusual, and tonia refers to muscle tone. And so this describes what many of you have been experiencing, that your muscles are behaving in ways that you don't want it to, or in ways that make it hard for you to function and carry out activities that you would like to engage in, or you must engage in. Dystonia is involuntary, And this is important for everyone to acknowledge because in the past it was thought to be due to psychological conflict. And so many dystonia patients were subjected to intensive psychotherapy. Even as recent as the 1990s, patients were sent to psychotherapists. But it is a problem that we'll see later on related to the software in your brain not sending the right messages to your muscles. It can be tonic. That means a posture that is steady, such as turning to the right. Or it could be mobile, so tremor-like. It may occur alone or as part of another neurologic condition. So commonly, people with Parkinson's disease also experience dystonia as one of the complications of their treatment. We also talk about dystonia, whether it's focal, so where it is located. Some of you may have blepharospasm, where it involves just the eyes, or it might involve just the neck, or the jaw movements. It could be segmental, so involving two adjoining body parts, so the head and the shoulder. Or it may be generalized, involving the whole body. The reason why I want to go over this is because many of the experimental treatments are targeting specific types of dystonia. So we need to know what type of dystonia you have in order to see whether you are eligible for that particular research project. The other terms for dystonia are acquired, which means that the dystonia occurs following brain injury or stroke or other problem in the brain. It may be inherited, and many of you who are following this topic probably know that in the past we only had one gene to identify an inherited form of dystonia. But more recently, there are so many forms of inherited dystonia that we have simply numbered them, and I believe at last count we're over 20. Idiopathic means we don't yet know what is the cause. And I think it's important for us as physicians and healthcare providers to acknowledge that we don't always know what is the cause. And the technology is improving every year. So what may be undiagnosable now, in the future may have a specific cause identified. Another way that we can refer to your diagnosis is that it could be primary, the cause is unknown, or secondary due to genetics. It might be drug-induced, so many people who are taking medications that act on the brain can experience dystonia. Or it may be secondary to brain injury, and that includes stroke, as well as traditionally what we think of brain injury after a motor vehicle accident or another traumatic accident. Dystonia plus refers to patients who have dystonia with other neurologic symptoms that make us think of a syndrome or illness complex, and so cues us to search further. And when we think about dystonia, genetics has to come into this discussion. So just look at all the potential genes that have been identified to cause dystonia. Most of these genes actually cause not just dystonia, but other neurologic symptoms as well. And there is often a history. So for those who have an X-linked illness, this means that you get the illness from your mother's gene, but it's only males who express the illness because they only have one X chromosome. It might be mitochondrial, and in the past we thought this was only inherited from women, but now we know that men also contribute to our mitochondrial genetic information. So you might inherit it from your father's family as well. Autosomal dominant means that for every child in a given family with the same mother and father, they each have a 50% chance of getting an illness from, let's say for argument's sake, the mother. Autosomal recessive means you have to have both your mother and your father affected in order to have the illness appear. I will comment that many of these genes that are identified here can only be identified in research settings. So it isn't something that your family doctor or even your neurologist or movement disorder neurologist can order. It's often something that requires referral to a genetics counselor and department. And so why is this important? Of course, it's important because for families where there is an inherited form of dystonia, parents may want to know what is the chance of their child also having this condition. It can also be important when there are other symptoms associated with the gene, and we want to make sure that we are properly providing preventative care in case there are things that we typically wouldn't associate with dystonia, and we need to keep checking to make sure this doesn't happen to the person. And finally, some patients actually work better when they have as much information as possible. And so they want to know as much information as they can about their condition. And this helps to give them a sense of control that they have an actual diagnosis, they have something that they can look up, and perhaps even a sense of community because they can identify with other people who have the same genetic condition. And the other reason why genes are important is because when we identify a gene, we can go backwards and figure out what does that gene tell the body to do, or what does that gene tell the cells to do. And this can give us clues to what can help the patient. So for instance, all these genes give a condition that for some of them, looks very much like Parkinson's disease and responds like Parkinson's disease. For others, it looks like dopamine responsive dystonia that occurs in childhood. And because of that, we know that dopamine is a treatment that can relieve the majority of symptoms for many of these patients, as opposed to other diagnoses where perhaps a metal is abnormally accumulated in the brain, and then we want to give treatments that can reduce that metal accumulation or reduce the absorption into the brain. And in these conditions, we might try treatments that improve the mitochondria, which are like the little power cells in each and every cell in your body. So we might give treatments that improve the power cell function so that cells survive. And in terms of genetic yield, I want to just give you that information because we as a modern society have such faith in science, and I think science is good, clearly, but science doesn't always have the answers. So even though patients have a childhood onset or a family history of dystonia, and therefore we really strongly feel that there must be a genetic cause for these patients, the yield is only 6% to 67% with what is called exome sequencing, where you do further genetic testing. So this is on patients who have already had basic genetic testing for known and common causes of dystonia. The highest yield was for those who had complex dystonia, so usually generalized dystonia, or those who also had intellectual disability, because many of these genes are known because of pediatricians' research into causes of intellectual disability. So this tells us that even though there are very advanced genetic testing and sequencing available, still only 6% additional patients may find an answer. This means as well that this kind of technology is very expensive. So 15 years ago, it was $15,000 to sequence the whole exome of a single person. Now that has reduced significantly, although in North America, it still is quite expensive and can be $5,000 for exome sequencing. So many provinces are not providing this type of testing. And what has been the historical evolution of our knowledge of dystonia? And this goes from 1893, where we first realized that dystonia is really a neurologic condition. For instance, writer's cramp was first described in bookkeepers in Victorian England, where they had to take long ledgers and just write numbers and numbers and numbers, and they started to develop writer's cramp. And at that time, they were thought to be functional, that is, that they did not have a real neurologic problem. It was because they didn't want to work as a bookkeeper anymore. And now we realize that it is this overlearned activity, and musicians also get a form of dystonia from a highly skilled, overlearned activity, changes the way the brain functions. And that in itself is a fascinating message and an important message to give a clue to those people who have that kind of dystonia, because rest can improve the hand function. So there are concert pianists who will rest for 6 months, practice for a month, and perform for a few months. Because every time they practice for long periods of time, their hand starts to get the musician's dystonia again. It also means that the brain is infinitely plastic. And when neurologists say plastic, we mean that the brain can adapt. The brain changes to what's going on. And this means that there is a possibility, as we will see in future research directions, there is a possibility that we could use that brain's adaptability and plasticity to actually address the symptoms of dystonia so that you don't have to come and see me every 3 months. Wouldn't that be a gift? You can have some other modality of treatment that might better address your symptoms. We also had in 1897 the first descriptions of generalized dystonia. And then in 1977, the use of thalamic stimulation for deep brain stimulation. And then various genes being identified throughout time, as well as the use of different kinds of botulinum toxin to treat dystonia. And this is, in fact, the first use of botulinum toxin. And it was used by physicians in the Army because when people had head injuries, they often had strabismus, which means the eyes aren't aligned from their head injury. And the doctors had access to botulinum toxin, and they used it to temporarily paralyze the muscles so that these veterans could see. And that expanded from there to in 1992, when I did my fellowship, we were just starting to use botulinum toxin for all types of dystonia. So think about that. That is in most of the audience's lifetime, and certainly my lifetime, that we went from not being able to do much to being able to do something that can offer at least temporary respite from an illness. From this cartoon, it is pretty complex, but this is your brain. This is the part of the brain that controls coordination. And these are parts of the brain, or the gray matter, that often control movement and sensation. Your motor cortex is up here, and your sensory cortex, which controls all the sensation information you're getting, is right behind it. This cartoon is just to illustrate, at least from the genetic disorders that we have identified, that there are multiple ways that the brain acts to cause dystonia. When I was talking about musicians and writer's cramp as a form of dystonia and that overlearned activity, one of the things that we found in these patients was that there is decreased intracortical inhibition. That's a fancy way of saying the brain is firing too much and it has lost the brakes to say, don't fire. And you see through here reduced excitability of inhibitory neuronal circuits, abnormal reflexes, and reduced inhibition. So again, it's losing those brakes. And if you think about your dystonia, it is like your muscles are just overactive. They've lost their brakes. They've lost that modulation. So it's like you're driving down the highway without any brakes. This is a frequent question when patients are initially diagnosed. Is it possible to have remission in dystonia? And this was, these were the results of a systematic review. And a systematic review means that the doctors ask all of medical literature a question, and they examine the evidence and try to get the best quality evidence to give you an answer. So their question was dystonia and remission rates, and dystonia and the patient factors that predict remission. They found that remission occurred in about 11.8% of patients. Partial remission, that is improvement of their symptoms, in 4% of patients. Remission rates were higher for people with cervical dystonia than blepharospasm and MEJ syndrome. So MEJ is when the eyes are closing and the jaw's involved. 64%, however, did experience a relapse during the follow-up period. And the people who were most likely to have remission were younger. That was the only factor they found among the patients that was in common. I think another interesting aspect of dystonia is we often think of dystonia as a motor problem because that's the thing that brings you to the doctor. My hand's not moving properly when I'm writing, or my face is doing things I don't want it to do, or my neck is turning and I can't shoulder check anymore. So we focus on those motor aspects, but in fact, when we look at other symptoms associated with people with dystonia, we do find that anxiety and depression are more common. Admittedly, we can't really determine whether it's because you're not moving the way you used to, that this is causing anxiety, or is causing depression because you cannot perform the way you wish at work or in your social activities. But anxiety and depression are higher among those who are currently having dystonia. Obsessive compulsive disorder is more common in some genetic forms of dystonia. And alcohol use disorder is more common in myoclonus dystonia, primarily because these individuals discover that their movements are very sensitive to alcohol. And if they are not informed of the risk, they start to drink more because when the alcohol wears off, their jerking and dystonia actually increase. So they again take another drink. Social phobia is seen in up to 71% of people. And again, you don't know whether it's the chicken and the egg. I suspect it's probably you have dystonia, you realize that people are interacting with you differently. Or if the dystonia affects your face, that is the first thing we present when we are talking to people and interacting with people. It's your face. And so it must change the way you interact and the confidence with which you can face others. Cognition can be affected in dystonia, although typically this is associated with some of the medications we use to treat dystonia. Sleep and energy can be affected because your sleep might be disrupted, particularly if you have cervical dystonia or generalized dystonia, because the movements themselves can actually impair sleep and make it hard to fall asleep. And pain is very common, particularly in cervical dystonia. 67 to 75% of patients do note pain, although many of my patients say, I don't have pain, but I have aching. And when we think of the usual treatments at this time for dystonia, for focal dystonias, the treatments of choice are really botulinum toxin injections, because the thinking is, as opposed to medications, this is targeting the part of the brain that, or the part of your body that is moving abnormally. It doesn't, however, get to the software that is affecting the muscles. Physical therapy is also important and can, as we'll see in future slides, improve the response to botulinum toxin. However, many physiotherapists are not trained on how to treat people with dystonia. And indeed, if you look at the literature and whether there are good guidelines to help an interested and motivated physiotherapist, there aren't any really good guidelines, except just use good physiotherapy principles, which isn't too helpful for those poor physiotherapists. Now, experimental treatments that I've highlighted here are the last box, which are transcranial magnetic stimulation or and direct current stimulation, which I'll cover in a cartoon to show you what exactly that is. For those who have generalized dystonia, that is, half of their body or their entire body is affected to a certain degree by dystonia, the treatment of choice is oral medications. And these include anticholinergics. The side effects include blurred vision, dry mouth, constipation, and confusion, or it can, in extreme states, cause hallucinations and delirium. So obviously this is not a great choice. Although it can be very effective. Benzodiazepines, so Valium type drugs, and this is because it works on a system in the brain called GABA, which is excitatory. So we want to decrease that excitation. And baclofen, which is used as a muscle relaxant and can be effective, although it also can cause sleepiness, drowsiness, and unsteadiness. Levodopa can be effective for people who have dopa-responsive dystonia because the brain is blocking the conversion to dopamine, and so we have to replace that for them. And then the medications, tetrabenazine and valbenazine, are also work on the dopamine system, but in an opposite way. They block or deplete dopamine, and unfortunately have become quite expensive, although they've been on, tetrabenazine has been on the market for some time, and it can be very helpful. The possible side effects of tetrabenazine are that it can cause Parkinsonism because it's depleting dopamine, and it might precipitate depression. And so this needs to be monitored for patients who are on this. Surgical techniques are often used for generalized dystonia when the dystonia is disabling. And these include stimulating a part of the brain called the globus pallidus and the subthalamic nucleus and thalamus. This is a really effective treatment. However, it is brain surgery. And so some people are a little more risk adverse. They may not want to try this. But other people have definitely benefited, and there is a very long history. They did state that in 1979 it was first used, but it was really used in a broad way starting in the 1990s and became much more accepted and actually a licensed use for deep brain stimulation, and there is a long history. These other surgical options are peripheral denervation. That means that the surgeon cuts the nerves in your neck, supplying the muscles to your neck in the case of cervical dystonia. This has never been subjected to good, rigorous research, and it does require extensive rehabilitation because you can imagine if you cut off the nerve supply to your neck is really unbalanced, and you have to then build up the strength again to get your neck to be straight. And in many cases, patients do require feeding tubes as well. So this is not often offered. Our center does not offer it. Thalamotomy and pallidotomy are similar to this, but what it means is when you see otomy, it means you are lesioning or destroying that part of the brain. These treatments use stimulation, and the benefit is if your condition changes and you need a different or more intense stimulation, that can be done by programming your pacemaker. When you have an otomy procedure, that is it. That part of the brain is destroyed, and we cannot change it or modulate it or dial it back. That's just it. There is a condition, there is a condition called dystonic storm. This typically occurs in people who have intellectual development problems, and dystonia is part of their condition, and they have had a febrile illness. Or in the past, we used to use baclofen pumps for generalized dystonia, and that has fallen out of favor because of the risk of having a dystonic storm and ICU stay. These are specific treatments for very specific types of dystonia, and I'll just leave it up here for you to read. We won't go over it in great detail. Now looking at, I said that deep brain stimulation is very effective for dystonia, but what about the non-motor symptoms that are more recently studied in dystonia? There were 52 studies of deep brain stimulation. None really documented anxiety, mood, and cognition, which were the most commonly noted complaints, but pain was commented in several reports of patients, and pain can improve significantly with deep brain stimulation. The motor symptoms improve by 26 to 78%. And I think this is an important message because, of course, people are concerned when we suggest surgery that patients did not have cognitive effects. There was some mild reduction in memory and fluency, but also some people did report that their thinking got better. So this is a hopeful message for those who are considering surgery. And looking at quality of life, I think we can look at measures that are important when the doctor sees you in terms of assessing your motor function, but looking at things like your quality of life. How has this made my life better? Is important too. And these studies showed that health-related quality of life improved, but because everyone's using a different survey instrument, it's really hard for us to tell how uniform that improvement is across different centers and different approaches. These are just an example of some of the injection studies that are being proposed for cervical dystonia, musician's dystonia, spasmodic dysphonia responsive to alcohol, an arm dystonia. You can see that there's a great deal of research activity in these areas. There's also research for deep brain stimulation in secondary dystonias in children, again, cervical dystonia, one looking at vocal dystonia, which can be very challenging to treat, and hemidystonia, as well as focal hand dystonia. This is an interesting study because it is looking at the evolution of deep brain stimulation methods and techniques. So when we look at deep brain stimulation for cervical dystonia, that overall patients do well, but they can have unintended other effects. So with the globus pallidus, they tended to have slowness in their hands. With the subthalamic nucleus stimulation, they can have dyskinesias, which are abnormal involuntary movements. So that looks like you're fidgeting and you can't sit still, or mood problems and weight gain. People who have vocal dystonia that has been challenging to treat might be heartened to know that there is this study looking at thalamic stimulation, and that after a good randomized controlled trial, hopefully we will find that it confirms the reports in single patients that have occurred in the past. Hand dystonia has also been examined with deep brain stimulation. And when I was talking about the different effects, these are traditional stimulators. And now with the new stimulators, you can actually change how the brain is stimulated, so you can make it look different, the area of the brain that's stimulated, and therefore reduce side effects and improve the effectiveness of deep brain stimulation. This is using what is called interleaving stimulation. Now, I told you I talk about non-invasive stimulation, and this involves either transcranial magnetic stimulation or direct current stimulation to treat various forms of dystonia. And what does this mean? Well, this is transcranial magnetic stimulation. So essentially the investigator puts a magnet on your head, and you literally feel a thunk-a, 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 thunk as the magnetic field changes. And what they're trying to do is stimulate either the sensory cortex or the motor cortex to try and improve the motor function. This is different than direct current stimulation. So rather than using a magnetic field to cause changes in the brain, this is using electrical impulses to cause electrical stimulation to the brain. Some of you may say, oh, that sounds like electroconvulsive therapy or ECT. And in fact, it is based on the similar technology, except it is using a much lower electrical amperage than ECT. So far, we've only had case series and some small randomized control studies looking at transcranial magnetic stimulation, and it does show that there is improvement in hand function, but we don't know how long that will last and whether that will be practical. So that's what the randomized control trials are for. And in terms of direct current stimulation, so far there are mixed findings with either no benefit or some improvement in musicians. Now, this is something that I feel should be more emphasized in terms of what we say to patients using exercise or physiotherapy. And I recognize that many people do not have extended health benefits to allow them to access physiotherapy, but it is generally safe and it doesn't have other side effects like causing you to be dizzy or confused. And so I think it's something that we should be using more often. There was a study looking at physiotherapy with botulinum toxin injections, and they found that the patients who had physiotherapy with their injections tended to do better. However, this is the description of the physiotherapy they had. It's pretty general. So stretching, active range of motion, where that means you're turning your neck yourself and trying to increase your range of motion, or isometric exercises, where you're trying to clench up your muscles at the same time. Subjects were required to exercise 15 minutes every day, 5 days a week. So that's a pretty low intensity exercise. I think that's something that anyone could fit into their schedule if they were motivated to do so. And as I said, it's really low risk. So in conclusion, I hope you see that research is expanding in dystonia, that open label studies, that is where we just take 5 of our patients and we do something to them, really doesn't prove effectiveness of an intervention. We have to look at it in a more rigorous way to see that it works. And simple things can work. So to try and engage in physiotherapy or exercise to improve your dystonia, and if nothing else, to improve your sense of well-being. Thank you. So I'll stop sharing my slides and we'll turn to Archana, who has reviewed some of your questions that you submitted on registration, and as well as monitoring the chat. So we can, she's multitasking.
Thanks a lot for that excellent presentation, Dr. Miyasaki. That was really interesting to hear about the whole pathogenesis of dystonia, and taking us through the history of dystonia. And I would say I especially like the part that you shed light on the non-motor manifestations of dystonia, which is, this has been quite a common question, along with the combination of a requirement of physical therapy with other treatments. So thank you so much for that. Before we move on to the question answer session, sorry if you can see my slides. Oops. I wanted to talk a little bit about some patient tools and resources that we have on our website. Now, since we know majority of people from Alberta are tuned in to the webinar today, I wanted to let you know that we do have support groups in Alberta, one in Calgary, one in Edmonton. Please do feel free to reach out to them. The information is available on our website. As well, we have various educational materials for patients. We had done a survey on dystonia patients, and we have that report it's called Real Patients, Real Answers. Then we have a new guide developed, thanks to Merz Therapeutics, they've developed this new patient-to-patient guide. It's quite an interesting guide. It's the guide by patients for patients, which talks about patient experiences and tips and tricks, and sections where there's notes that patients can make notes on. So please do check that out. We also have for awareness and 8 purposes, the Dystonia lanyard that's newly developed this year. and also fitness videos by our ambassador, Casey Kitson, where she's done 3 videos on core stretching and cardio. And we do have a COVID-19 webinar where we had COVID-19 questions answered in that. All of these are available on our website, www.dystoniacanada.org/mydystonia. Please do visit that page and you will have links to all of these resources. We also have a contest running for the first 5 people who registered and attended this webinar. They will win a Yoga for Movement Disorders book, courtesy of Merz Therapeutics. So please watch out for that. We will announce the winners in the first week of October. Okay, moving on to the Q&A. We had a couple of questions asked. Oh, I see the number of questions have gone up. So a couple of questions asked in advance of the presentation and some during the presentation. So I will start with a patient who has talked about access to treatments like ultrasound-guided botulinum toxin injections in Alberta, Canada. They would like to know if that's available in Alberta. If you can share that, Dr. Miyasaki.
So there is some controversy about whether ultrasound or electromyography is a better modality for injections. And one of the research studies that was registered is in fact looking at that because physicians vary in their approach, and I personally use EMG. I have used it for 30 years, but I use it on almost all my cervical dystonia patients. I know that that's unusual. Ultrasound-guided injections are also possible, and it helps you to localize muscles that are moving, but again, you still have to figure out what is actually causing the movement. Ultrasound-guided injections are provided in Calgary, and EMG is done in Edmonton. I'm not clear that in Calgary they do EMG, and I know that in Edmonton, to date, we haven't been using ultrasound, although we're looking at it.
Thanks for answering that, Doctor. Another question would be, why does botulinum, sorry, I'm going in order of treatment, so why does botulinum...
You're very soft, Archana. Can you speak up a bit?
Is that better?
Yes, that's better for me.
Sorry about that. Why does botulinum toxin work on some and not the others? Are there any alternatives to botulinum toxin in such cases?
There are some patients who are primary non-responders to botulinum toxin injections. I would say that it also depends on who is doing the injection because it is highly skilled based. So most movement disorder neurologists would spend 1 to 2 years learning how to do injections. And although there are very few movement disorder neurologists in Canada, they are the most trained to do injections for movement disorder patients. Other physicians do provide injections, and the duration of their training, I think, will predict how well patients respond. Because I'll give you an example where I train. Essentially, I was responsible for injecting all the patients twice a month. So I injected about 100 patients every month. So you just learn how to, what works and what doesn't work, and an approach. I would say, so that's one aspect is the physician specific. Then occasionally patients have very complex dystonias that do not respond well. So people who have their neck come forward, they often do not respond well because if we inject the muscles that cause that pulling forward, they often end up getting very bad swallowing problems. So we can't do it optimally. Another common one is head shaking. It can dampen the head shaking, but definitely it doesn't make it go away. And if you have very marked head shaking, it will not improve significantly. And spasmodic dysphonia is one of the conditions that either it responds beautifully or it does not respond at all. And so looking for experimental treatments that can help these particular patients is really important for the field. And you can see that many of the conditions were very specific to these disorders that haven't responded well in the past. So musicians' dystonia, musicians tend to be not so happy with the botulinum toxin injections because their hand function is so precise. And so looking at a different method to treat these individuals is probably going to have to happen.
Thanks for covering that, Doctor. I'll move on to my next question. Someone has asked, they've been on the same medication for over 20 years and it has had an effect on his brain and memory. Are there any alternatives to this?
So again, it's very specific because medications are used for generalized dystonia and would not be the treatment of choice for focal dystonia. So it really depends on what type of dystonia this person has. And I think, we went over many of the medications that are used, and many of them, because they're acting to improve dystonia, act on the brain. And so they do have effects on memory and can have effects on mood as well. And so that is something this person should speak further with their own neurologist.
Okay, thanks. Have there been any studies done on adrenal health in dystonia patients, like vitamin, mineral levels and deficiencies?
Not to my knowledge.
Okay, and a person has asked, what are the results from the study of vocal dystonia using DBS, if they have been completed and are available?
No, so all those studies are in progress. So, okay. And none of them have been reported.
Oh, thank you. Next, I have a person has asked about spasmodic dysphonia. Are there genetic causes for this type? And are there any new treatments for spasmodic dysphonia?
There is one gene for a disorder called whispering dysphonia. And so that is the type of spasmodic dysphonia where your voice is very soft and you cannot generate a large volume. The genetic test for that, because it is a very specific dystonia, is at least not available in Alberta, but might be available in Ontario. What was the second part of the question?
Are there any new treatments for spasmodic dysphonia?
So the research was looking at possible brain stimulation or using transcranial magnetic stimulation for some forms of vocal dystonia. And I think that is going to be the future for the patients who do not respond easily to botulinum toxin.
Perfect, thank you. And I think I'm gonna ask the last question we have here. Have you ever seen an improvement in oromandibular dystonia?
So do you mean remission or do you mean?
I guess the patient's asking if there has been any dystonia patients where you've seen, I guess, any progress.
So many patients respond to botulinum toxin, but incompletely. And so that is the treatment of choice at this time. To date, most of the cranial dystonias do not respond well to deep brain stimulation, and so they've not used it. Although it is interesting based on individual cases responding to lesions in the brain, that they are pursuing deep brain stimulation for vocal dystonia. But generally, whenever I ask our surgeon to see a patient who has oral mandibular dystonia, we're told it really doesn't work.
Oh, okay. Thanks for the information on that. I guess we've covered almost all questions. Oh, sorry, I have one more. The person has asked, on genetic testing, how do you determine which types of genes is required to achieve full coverage? I've had genetic testing done 3 years ago. Do I have to undergo more testing soon?
So genetic testing does change. However, in the 3-year horizon, usually not, unless there is something specific for your condition. You can always check in with the geneticist who provided the original genetic test and say, just checking in, is there anything that you have available now that is relevant to me? Because I did have one family who came and they said, well, we're all tall and everyone thinks we have Marfan syndrome, but my dad had genetic testing 10 years ago and they didn't find anything. And I said, well, that was 10 years. Let's send you again. And they did find a gene because there was something identified in the intervening 10 years. So I would say that having periodic testing is helpful, but it really depends on how available genetic testing is in your province. I know that our neurogeneticist has a 2-year wait list. So I would say that having checking in every 5 years would be appropriate.
Okay, thanks. That's great to know, actually. We do get these questions sometimes at the office too, so that helps.
And I think, so clearly this person had the genetic test, they went through the counseling, but for those who haven't had genetic testing, you have to think, what are you going to do with that information?
Mm-hmm.
And if other people in your family have a similar condition, if you get an answer, it inevitably discloses information to them that they may not have wanted. And so how do you handle that?
Mm-hmm.
You have to think about that ahead of time so that you're mentally prepared and you know what you're going to say to your relatives, because you may choose not to disclose if they have indicated they're not interested. Or similarly, if you have minor children, they cannot be tested unless it is a condition that can be treated or cured in childhood. So when they become adults, do you disclose then?
Mm-hmm.
So there's all these questions that you have to kind of go through in your head before you get the test done, because it's not just a test for you, it's genetic. So it's a test that ends up affecting your family.
Oh, yeah, that is true. Thanks. It's very useful. Okay, I guess that's about all of our questions, and we're almost out of time. So I wanted to thank you so much, Dr. Miyasaki, for taking some time out and doing this presentation and shedding light on various topics within dystonia. And I just wanted to just a note for everyone that DMR of Canada is not recommending any specific course of treatment. And reminder, any new or experimental treatment mentioned today may still be relatively new or exploratory at this time. Please speak with your movement disorder specialist about any course of treatment to ensure it's right for you. And I want to also take a moment to thank Merz Therapeutics for their very generous support of the mydystonia&I webinar series. And this is happening during Dystonia Awareness Month of September. A reminder that recordings of all these webinars will be available on our website in October. We do have 3 more webinars coming up until the end of September. So if you haven't signed up already, please do sign up. Thank you once again, everybody, for joining us. I hope you like the webinar. We hope you can tune in for the other webinars as well. And have a great evening and a great afternoon. Thanks again, Dr. Miyasaki.